Okay, so from my records, we are done with musculoskeletal disorders. So we are moving to nervous system disorders. Nervous system disorders. Please, if you can hear me or if you cannot hear me well, let me know. Just raise up your hand and I will know. If my voice is not clear, let me know. If it is clear, then that's okay. So Parkinson's disease is the first condition we want to start. Parkinson. Parkinson. It looks like somebody's name. So how did the condition came about? How did it start? How does it present its features? And what are the major signs and symptoms, clinical management, both medical and nursing? How do we prevent it? We're going to go through all that. So the condition is progressing. Progressing means it starts from one, moves to two, three, four, five. It moves on as you don't bother to put brakes on it. You just move on. It progresses. It moves on in higher order. So we're saying that Parkinson's disease is a slowly progressing neurological movement or disorders. So it's a movement disorder. And the movement disorder starts and eventually you become disabled. So it starts affecting your movement. The condition involves the nerves. That's why it's a neurological movement disorder. So it involves the nerves, and once the nerves are involved, then it affects your movement if you don't put brakes on it. Then after that, you become disabled. You cannot move at all, bedridden. So who are those at risk for the condition Parkinson's? Who are those at risk? One is aging. Once you age from 60, 60 plus, 70, 70 plus, and above. So young adults do not normally experience Parkinson's disease. Generally, it begins in middle or late life, and the risk increases with age, as I've already mentioned. Usually, people develop the condition around the age of 60 or older, 65, 70, 75, and above. So age becomes a risk factor. As you age, the chances of experiencing the condition increases. Then the second risk factor is hereditary. The condition is related to family. If there's one in the family, there's more likelihood of you experiencing the condition. So it runs through the family line. Having a close relative with Parkinson's disease increases the chance that you will develop the disease. However, your risk is very small unless you have many relatives in your family with Parkinson's disease. So even though it's right in family, unless those who are at risk of passing the disease are more than one. Hello. Please, let's move on. Some dogs were making, they were barking. I wanted to calm them down. So, can you hear them? Can you hear them from the background? They are disturbing.
No,
No,
please.
sir. No,
No,
sir.
sir.
Oh, you can't hear them. That's fine. That's fine. Okay.
Release them and we'll chop them.
We chop them. Hey, they are big, oh, big ones. Use 1 week to eat their flesh. Big ones. Okay, so the risk factors also affect men more than the women. So I was trying to do some small research why the risk factor for Parkinson is more linked to men than the women. So men are more likely to develop Parkinson disease than the women. So why? Who can tell me from your experiences, from the world? Who can tell me? Yes. Good. Yeah, that's fine. Good. Yes, who can tell me? Why the risk increases with men than women? Okay, we will get to know as we move on. We'll get to know as we move on. So the risk increases with men. Exposure to toxins. There are some people. Okay, Isa, help us. Why the risk for Parkinson increases with men than women?
Yeah, good evening, sir.
Good evening.
So for me, I think I'm just looking at it from this point of view because I feel because men are more into combative sports, especially with most incident being men that are more into aggressive sporting activity. Most of them end up with that kind of condition. That's what I'm thinking.
Yeah, I think you may be right in a way. When it comes to, okay, let me hear from Emmanuel. Emmanuel,
Hello,
yes.
sir.
Yes.
Yeah, sir. I also think our dopamine levels or secretion of dopamine levels between men and women are different. Okay, so that puts men more at risk of getting Parkinson's disease more than women.
Come again, Ima, come again.
Hello, sir.
Yes, come again, Ima.
Sir, I was also saying that the brain differ in dopamine system. So the differences
Okay,
make men more vulnerable to degenerative sin in Parkinson's
okay,
disease more than that of the female.
okay, okay,
Yes, sir.
okay,
And then
okay.
also the females, their estrogen and then the progesterone sometimes appear to protect that dopamine producing neurons in the brain. So
Yeah,
they reduce their risk than the men.
okay. Okay, very good. So you've done well. You've done well. So it's all due to exposure to aflatoxins, stress, and the kind of psychological trauma we go through as we live on this earth. Men are more exposed to a lot of psychological effects, psychological related to financial, relating to relationships, and so many things. Work related stress are also a factor, infections, and even physical activities like military, where they will be slapping you several times. The ladies, they don't slap them like that. So the risk exposure increases with the men than the women. So in all these exposures, it is skewed more to the men than the women. So that is also the reason. You see, the kind of things the men will do, women will not do. Yes. So that is what happens. And exposure to herbicides and pesticides increases the risk of Parkinson. Those farmers who spray their crops with the herbicides and the pesticides, they don't even cover their nose, their mouth. These insecticides, they inhale, enter into their system. And once you inhale those pesticides and insecticides, it attacks your neurons, your brain, and it starts causing degenerative changes in the brain cells. So causing more problems with Parkinson. especially now that we have the mining centers, the galamsey centers, the chemical they use to extract the gold, the lead, the mercury, the arsenide, and all those chemicals are very toxic to the brain. Once we are exposed to the substances in water, like it's raining now, so as the sun washes these chemicals to join the rivers, we are more or less likely to fetch these rivers and drink them. We use them on our crops, and the chances of we getting them inside our bodies is high. And once they go inside our bodies, they start affecting our brain, our neurons, and exposing us to these conditions. So be careful about how you go about your eating, your drinking habits. Okay, so we have the risk factor, then we have the actual causes. Let us look at actual causes. The first cause in Parkinson's disease, the nerve cells or the neurons in the brain gradually breaks down. So we lose a number of neurons. And these neurons produce chemical messengers in our brain called dopamine. Dopamine. So once we lose these nerves as a result of aging, as a result of these chemicals we are exposed to, as a result of infections, all these factors affect these neurons or the nerves in the brain, and we lose them. So the number of nerves or neurons that we lose affect the production of this dopamine. As the number of nerves decreases or we lose them, dopamine levels also decline. So these nerves are responsible for producing this dopamine. And as they get degenerated and we start losing them, the amount of dopamine that we're supposed to have also goes down. When dopamine level decreases, it causes abnormal brain activity. So we need normal dopamine levels to give you maximum brain activity. And once the level of dopamine declines, it leads to impaired movement. And this causes the disease known as Parkinson. Parkinson. The actual cause, in fact, it is not known. The actual cause is not known. So there are so many theories that talks about how Parkinson's disease can occur. But we don't have specific cause as this is what really brings about Parkinson's disease. We don't really know. But what we know from the books is that as the brain cells start declining, it affects the level of dopamine, also declines. Hello, Samuel. Please, I'm having a lecture. I said I will call you. I'm having a So let us look at the pathophysiology of Parkinson's disease. So as we said, it is related to the level of dopamine. And as the dopamine level decreases due to destruction of pigmented neural cells in the substantia nigra, there's a portion in the brain called the substantia nigra, the stratum corneum. That is where these nerves are found mostly. And that is where they start producing a lot of dopamine, these nerves. So the substantia nigra, found at the basal ganglia of the brain, is responsible for producing dopamine. So the nucleus of the substantia nigra projects fibers of neural pathway to the corpus stratum, where neurotransmitters are key to control complex body movements. So we have these number of nerves, and these nerves project and they will move through the corpus striatum. They are neurotransmitters. So these nerves release neurotransmitters, and these neurotransmitters, dopamine is one of them. And they are produced to control complex body movements. So I tell you that the ladies who do catwalk, who do fashion, who walk like cats, they have a substantial number of dopamine. Their dopamine levels are high. And these ladies are very active. They do a lot of exercises to boost their dopamine level. And I'm telling you, if you want to boost your dopamine level, start engaging in active exercises. Once you engage in active exercises, the nerves become sensitized and they produce a number of neurotransmitters, including dopamine. Dopamine levels increases. It affects and gives you a number of complex movement. So the complex movement here is key. If you want to produce complex movement, then you must think about exercise to boost the dopamine levels so you can walk majestically like a catwalk. That is one thing here. Through the neurotransmitters, we have acetylcholine. So one of the neurotransmitters is acetylcholine, which is excitatory, and dopamine, which is inhibitory. So we have the acetylcholine excitatory and dopamine inhibitory. So the striatal neurons or the nerves relay messages to the higher motor centers that control and refine body movement. So these nerves, they relay with the brain, and the brain gives us a number of complex motor movements. The loss of dopamine stores in this area of the brain results in more excitatory neurotransmitters. So once we lose dopamine, the brain results in more excitement, because in a certain amount of time, you should have, for example, if we have 20 kilos of acetylcholine, we should have 20 kilos of dopamine. So the dopamine levels, which is the inhibitory, balances the acetylcholine, which is excitatory. So that gives you the fine, precise body movement. In a situation where you lose some fibers, some nerves that's supposed to produce dopamine, and as a result, dopamine level goes down, and you have a higher levels of acetylcholine, which is excitatory, then you have created an imbalance between acetylcholine and dopamine levels, in which case you have at that point more excitatory movement than inhibitory movement, because inhibitory movement is produced by dopamine level, which is already low, and excitatory movement is produced by acetylcholine, which is already high. So if you have higher levels of acetylcholine and therefore excitatory, that's supposed to balance with dopamine, is now having lower levels of dopamine, which is inhibitory. So the movement becomes imbalanced and uncoordinated. And that is the hallmark of this particular condition called Parkinson's disease. Please, do you understand the pathophysiology? I want you to get the physiology clear so that you don't have difficulties understanding their management and how you can help people live longer and become more active. Do you understand the pathophysiology? So the loss of dopamine stores in this area of the brain results in more excitatory, as I just mentioned. So leading to imbalance that affects body movement. We have stages. Thank you. Thank you, Emmanuel. We have stages. I will summarize it for you, don't worry. I will summarize it so that you can get a gist at the fingertips. So you can just explain to student nurses about Parkinson's disease and how it progresses and affects movement. Okay, so we have stages. So before we move to the stages, yes, so let me just give you a summary of what we have done so far so you can really get it on your fingertips. We said Parkinson's disease is a disease that is slowly progressing. It affects the brain cells, and the brain cells degenerate. They lose the number of cells due to factors we have already mentioned, like infections, hereditary, aging. They are all factors. Aging. As you age, you lose these nerves. And these nerves are responsible for producing these neurotransmitters, including the acetylcholine, which is excitatory, and the dopamine, which is inhibitory. At a point where you lose a number of dopamine neurotransmitters, the neurotransmitters for dopamine levels go down as against higher numbers of acetylcholine, which is excitatory. So that imbalance is created, and you have more excitatory movement than dopamine, which is inhibitory movement. And this brings about abnormal movement of this particular condition. Okay. And this happens at the substantia nigra, which is situated closer to the basal ganglia of the brain, the basal ganglia. And their fibers project into these pathways, and then as you lose these numbers, you lose the dopamine levels, and then that creates imbalance, causing these abnormal body movements. I hope it is clear. I have really given you a summary of what's really transpired before the stages here. So the early stages of the condition, we have early symptoms of Parkinson's disease, usually mild and typically occur slowly and do not interfere with daily activities. You can go about your duties undetected. Nobody can know that you are suffering from Parkinson's disease. So it can occur years after. Nobody will be able to notice it. Sometimes early symptoms are not easy to detect, or you may think early symptoms are simply normal signs of aging. You might think that, oh, the person is forgetting about things. Hey, the person is falling down. I can cite an example. I use my own auntie, that is my father's sister. So that is my aunt, right? Those international people, you have to correct us. That's my aunt. Good. So they didn't tell me before I realized they have gone to do fibroid operation. They said, I asked why they went to do fibroid operation for her. They said when she walks, she falls down. And I'm saying, when she walks, she falls down. Is it the cause of fibroid? That the fibroid symptoms? I don't know if you can tell me. Maybe they have added falling down something to fibroid signs and symptoms. And they have to take her to some hospital for some unqualified surgeons, and they did fibroid operation, myomectomy for this is my aunt. And this my aunt passed on. She didn't recover. She died through the operation. And the reason they gave me was that on auntie I know what he has. No, is it a sign of fibroid? I got confused. So this was a typical sign of Parkinson. You understand? It affected her movement drastically because she has lost some number of brain cells, and therefore there was more excitatory than dopamine. So the walking movement was not balanced. There was uncoordinated movement, and that was putting like if as you walk, as like somebody is pushing you from the back. So she falls all the time, and that was a typical sign of Parkinson. Instead of consulting to get the right treatment, they took her that because of the fibroid, she's experiencing this. And some Dr. Bia, 1 year experience, did this and she killed her. Myomectomy, she died. You understand? These are some of the things. You might think that it is as a result of aging, these things are happening. It is not easy to detect these conditions. You understand? At a point, you may have fatigue or general sense of uneasiness, or you may feel slight tremor, or you have difficulty standing. It affects standing and so many things. You can't move easily, uncoordinated movement, standing, easy fatigue, a whole lot. That is the early stage. Then we have the mild stage, So the mild stage symptoms start getting worse because you have not put brakes on it. It is difficult to put brakes on it. If you don't notice it early, you can't put brakes on it. So at the mild stage, symptoms start getting worse. You start experiencing tremors, muscle stiffness. Your muscle becomes stiff at the joints. And there's movement problems. These movement problems now affect both sides of the body. So movement becomes very, very difficult. balance problems, and falls are becoming more common. So that was the situation of my aunt. Falls were becoming more common. Even as she wants to go to church, she will fall down. So it was uncomfortable and they were getting more confused. So you, even at this stage, you can still be fully independent, but duty of everyday living, somebody needs to help you, such as bathing, dressing, cooking, becoming more difficult to do and take longer time to complete a task. Very simple task. It will take you so many hours to complete a simple task because of the neural problems. So that is the mild stage or the middle stage where the condition becomes more critical. So mild late stage. So standing and walking are becoming more difficult and more may require assistance with a walker. So now you can no more stand or walk around until you use a walker or a wheelchair. You may need full-time help to continue to live at home. So somebody needs to be with you. You may need a house help to assist you with your daily chores, bathing, cooking, eating, a whole lot, sweeping. Somebody needs to be with you and help you with your daily chores. Then the advanced stage, you now require a wheelchair to get around or you become bedridden. You may experience hallucinations and delusions. You may require full-time nursing care at home. So that is how it is. So at the late stage or advanced stage, you are completely down, completely down. So where you even have signs of hallucinations and delusions coming in here. Yes, Seth Wilson, I don't know. I normally give you time to ask questions. I don't
Hello,
know whether,
sir.
yes,
Good afternoon, sir.
good afternoon.
So I was thinking about your auntie,
Yes,
the fibroid.
yes.
So could it be that maybe she was having some episode of bleeding because of the fibroid, and maybe they attributed that to the dizziness that she was having?
Yes. It could also
Yeah.
be a factor. It could also be
Yes.
by that
Yes.
because she was bleeding, it was affecting her hemoglobin levels, and
Yes.
that may be causing dizziness. That could have been resolved easily. And me, I know she was having post-surgical bleeding, and that could be as a result of anemia and other things. So
Yes.
this problem could have been resolved by just trying to maintain the hemoglobin levels at a normal state before the surgery. So
Yes.
why should you do surgery when the HB is not okay and creating problem with post-surgical bleeding? I mean, how?
Yeah.
You
Yeah.
can't understand. You see, very, very, very painful. But what do you do? Because
Sorry for that.
they didn't consult anybody. So I also felt quiet. I was sad, but I was just quiet. You understand? The time where Poku were in school, she was taking care of us. So we gave it necessary to also could have at least gotten back to her. But what can you do? And just a simple myectomy, you kill somebody like that. So painful, very, very painful. And these doctors nowadays, you have to be careful with them. I always tell you when I'm teaching you, there are funny doctors, and most of them fee paying. You understand? Fee paying. And you have to be careful visiting them at their private places. They want money. It's all about money, not committed to the work. No. Even if she does, if she can't even do it, she will do it because of the money. She will do it. He's looking for the money, not the quality of work and saving lives. You understand? So it's so painful. What can you do? Let's talk about the signs and symptoms. Tremors because of the nervous involvement, slow body movement. The term is bradykinesia. Bradykinesia, that is slow body movement because of the nerves. You see, there's imbalance between dopamine and acetylcholine. So you experience this rigid muscles, or it's because of this impaired posture and balance. So loss of automatic movement. So before you move, you take so much time for you to even make a step. You understand? So speech changes, your speech becomes slurred and it takes a long time to complete a sentence. So bad. Writing chest, that is the nature of the condition. As you are writing, it's like you are writing your chest, something like that. Depression set in because you are unable to do what you used to do. You are unable to have sex or meet your partner if you are a male, and that creates more depression. Your wife will be moving to and fro. You can't do anything. Yes. And that gives you more depressive mood. You understand? Just common bath, you cannot bath yourself. You cannot cook and feed yourself. And things you used to do for yourself, you can't do. And all this increases chances of depression. You have dementia, and dementia is just the late sign of the condition. Sleep disturbances. You experience signs of insomnia, have difficulty sleeping. So decreases facial expression because of the nerves. The nerves are affected. So your facial expression is drastically reduced. You cannot have smooth facial expression. Chewing and swallowing becomes a problem. The nerves are affected. Urinary problems, you have incontinence, loss of smell. So even your olfactory nerves are all gone. Lack of interest, you become so apathetic in daily, everyday life. So somebody should be by you, trying to create some kind of interest and entertain you. How do we diagnose the condition and how do we do our test? So diagnosing the Parkinson's disease is sometimes difficult. I've told you at the early stages of the condition, it's very, very difficult to diagnose. Since early symptoms can mimic other disorders and there are no specific blood tests or other lab tests to diagnose the disease, it's difficult to detect. Imaging tests such as CT scans, MRI scans may be used to rule out other disorders or other conditions that cause similar symptoms. So you want to rule out like epilepsy, whatever. You want to do differential diagnosis. So you keep on taking history, then medical history, physical examination, or to unravel really what is happening. Then your nursing management, you encourage the patient to participate in exercise. Why exercise? Because at the beginning of this lecture, I told you that the best antidote for progressing or for putting brakes on this condition is exercise. As you exercise, you sort of increase the amount of dopamine that's supposed to balance with acetylcholine. It's through exercise that you can do that. And once you do that, you try to correct those. Hey, you are disturbing. You are disturbing, please. You did not bring your name. Say Zoom user. Mute your microphone. You shouldn't disturb the lecture like that. And bring your name. Don't use Zoom user. Bring your name so that we can mention your name and call you to order. I don't want to see Zoom user. So administer the prescribed medication as doctors give prescription, administer them. So increase fluid intake and diet full of fibers to prevent constipation. So taking more fluids, just prevent constipation by giving food that are full of fiber and roughage. Advise the patient to take time when eating because of the slow chewing, having problems with swallowing and chewing. Don't rush the patient through eating. You choke the patient. Help the patient on the speech exercise to improve communication. So communication is impaired, and therefore you must always help with speech problems and improve communication for him or her. How do we prevent this condition? We don't know the cause, the actual cause. We don't really know. So proving ways to prevent the disease also remains a mystery. Some research shows that people who consume caffeine, which is found in coffee, tea, cola, Parkinson's disease less often than those who do not drink it. So it means that coffee and those things will predispose you than those who do not take them. Complications of Parkinson's disease. You have thinking difficulty, So you cannot think through issues, depression and emotional changes, chewing and eating problems, sleep problems and sleep disorders, bladder problems, incontinence, constipation, sexual dysfunction. That is what causes the depression. Any questions so far?
Avidopa.
So many hands are up. Okay. So I have Beatrice, I have Regina, I have Desmond. All your hands are up. So let's hear Beatrice, then Regina, then Desmond, and then Millicent. Let's hear you.
Sir, good afternoon.
Good afternoon, Beatrice.
Please, sir, I wanted to ask, are there types or classification of this condition? Because I know of a friend, she can do any other thing except that when she holds a pen, then she
Mhm.
just writing. She can't write. The hand will be
Yes,
shaking like that.
that is the chest writing chest.
Okay. So
So
is it
that
a
is that
form?
that is the stages I took you through. That is the early stages. So that is the early stages. You remember I took you through the stages. Were you
Yes.
there? Very
Yes,
good.
please.
So
But she
from
doesn't
now,
experience any other symptom apart from
yes,
the writing.
yes. So it means she can work on it. When we take her through exercises, physiotherapy, exercises, you see that you start producing some amount of dopamine and you see that the level of tremors and those signs of problem writing goes down. So we can still help her through physiotherapy, right?
Okay, thank you.
Yes, very good. Yes, and any other, yes, yes. Let's hear those who hands were raised. Let's hear you.
So,
Yes. Evening.
please considering the fact that we said low level of dopamine person by the diet, can we also get a way to measure the whether it is low, uh, uh,
Your voice is not clear. If you could come again so that we can hear you well and answer you. Yes, so come clear. I
okay, so
wasn't getting there.
I was asking about the dopamine level during when we're doing the pathophysiology. We spoke about low level of dopamine to also be the cause of the disease. But during the diagnostic mechanisms, I didn't see anything like that. And I want to know whether we can be able to measure the dopamine level to know whether it is the cause of.
Okay, so what we can do is to do the CT scans, MRI to check the amount of nerves that is that is accumulating around the substantia nigra, close to the basal ganglia of the brain where these neurotransmitters are produced. So once we know the amount and then the quantum of these nerve cells, then we can relate it to whether we have low dopamine or we have less dopamine. Do you understand?
Yes,
That is
sir.
why we do.
Thank you
That
so
is
much.
why we do the CT scan. Please, do you understand?
Yes, sir.
Oh, very good. Okay. Yes. Then we have who else? Those who hands were raised.
Sir, please,
Yes.
I'm here. Good evening.
Evening, Regina. Yes.
Sir, please, I would like to know the difference between dementia and Parkinson's disease. Thank you.
So Parkinson's disease will lead to dementia. Dementia is the brain becomes absolutely gone. Gone. You cannot just do anything. So it is the roadmap to dementia. Parkinson's is one where the brain becomes absolutely.
Sir, please, you can't be heard.
You can't hear me?
Sir, please, yes, I
Please.
didn't hear anything. I couldn't hear you.
Okay, then
And even
let's
with
tell
the
you
first explanation.
explanation to the one who asks about the level of dopamine.
Yes, that one too didn't come.
Okay, but now can you hear me?
Yes, sir.
Yes, sir. It's
Okay.
on and off.
Then it's raining. That is not my fault. You know, when it's raining, the network becomes bad. And when the network is unstable, it affects the sound quality. Because I'm just speaking through the mouthpiece and the microphone is 100% open, the volume. So it's the internet or the network that is causing this abnormal sound here. When I started, the sound was clear, but now it's drizzling. It's like raining, and the weather is not that good. But we try to manage it. So initially, the explanation to the first question was, how do we measure the amount of dopamine so that we will know whether the person is really experiencing Parkinson or not? And I said it is difficult. You know, in the lecture slides, I noted that it is difficult to detect the condition, difficult to diagnose them at that early stage. It's very, very difficult. However, what one can do is to go for diagnostic investigations, radiological investigations such as CT scans, MRIs, and this can tell the amount or the level of the nerve cells in the brain, and specifically around the substantia nigra, closer to the basal ganglia. These nerve cells normally is related to the amount of dopamine that's supposed to be produced. So once you have low levels of nerve cells around the basal ganglia, then definitely is relating to low levels of dopamine. But once you have more neural cells closer to the basal ganglia, it means that you have higher levels of dopamine. So we use the number or the amount of dopamine relating to the amount of neural cells closer to the basal ganglia to know whether we have high or low levels of dopamine. That was the explanation I gave. And the next question is asking specifically about what was the next question saying? What was it saying?
Sir, please, I was asking that what's the difference between Parkinson's disease and dementia?
It's the roadmap, it's the progression. You start from one, you are not having dementia, you are having only these tremors and then difficulty walking, and you don't put brakes on it, the condition progresses. As the condition goes from 1 to 10, which is the pivot, then the brain becomes degenerative, and gone. The brain cells are gone. Complete degeneration leads to dementia. So that is the progression. The condition Parkinson's will take you through dementia. Dementia is the last result. I hope it's clear.
So your voice is gone again. We can't hear you.
I can't do anything about it. I have even raised my laptop and I speak through the microphone. I don't know what I should do again. It is the network, probably from your end.
Yeah.
It's not my end.
It's
Probably
come clear and go.
it is your end.
Okay.
Please check your network because I don't know what I should do again. And it's only you who is complaining. So it's your network. It's not everybody. So check your network, please.
Sir, please, it's not only hell.
Sir, it's not only hell, it's fluctuating.
Please, some of us are also experiencing the same thing.
And it's raining. It's raining.
The same thing here. The same thing here.
have changed the network to a broadband. I don't know. Let's see how it also goes. Is it okay now? Hello?
Yes,
Far
sir. It's
better.
better.
Okay.
Yes, sir. It's
This,
better.
Sure, sir. Now we can hear you.
this is better. Okay,
Yes.
so that was empty and that was disturbing. So I have changed it to broadband. And this is clear. So let's now discuss those things that you didn't hear, those before we move on. So the difference between dementia and Parkinson I have explained that the Parkinson will take you to dementia if you don't put brakes on it. It starts with the destroying some brain cells. And if you don't put a brake on it, then all the brain cells become degenerated. And that is where you develop a dementia. That is it. So dementia is brain cell degenerative, total destruction of the brain cell. And that's where the brain can no more do anything. Vegetative. So that is it. Parkinson is when you start losing a number of brain cells. You can do everything. And as you progresses, you lose more brain cells. And until you become completely lost and generate all the cells, and that is when we try you have dementia. Okay, any question, please? Yes. Yes, please. Pinoria, your hand is up. And I'm calling. Emmanuel.
Yes, sir, because it's two of us whose hands are up, so I didn't know I was there. Sir, please, about the diagnostic investigations. Sir, somebody asked earlier,
You
but I
have a
think
noisy background. Pinoria, you have a noisy background. Step it up. Sometimes when you want to talk, check your background. So noisy. So noisy.
Hello, sir.
sir, please, is it
Yes,
okay
Emmanuel,
now?
okay, all right. Okay. Yes.
Okay, sir, now I was asking about the diagnostic investigations. That can we measure the level of dopamine to state if it could also be the low level of it, the suggesting Parkinson disease?
But I have answered that question. Somebody asked. I don't know whether you didn't hear.
Yes, sir,
Somebody asked the
thank you.
same
I think I
question.
didn't hear it. Yes, thank you.
I said you have to do the MRI, CT scan to know the number of brain cells. That is related to the level of dopamine levels. Okay. Okay. Yes.
Hello. Hello, sir.
Emmanuel.
Yes, sir. Sir, please,
Yes, Emmanuel.
to add to what you said about the differences between the Parkinson's and then the dementia. So I also want to add something to what you said. And
Okay, let's hear.
you see, the Parkinson is primarily the movement. It's a movement disorder that is caused by the dopamine producing neurons in the brain, while the dementia is a syndrome characterized by memory loss, difficulty in speaking, reasoning, and then sometimes problem with
It is
language.
because of the loss of the cells that is causing all that. So the bottom line is the losing the number of neural cells. You understand? The memory loss, whatever you are talking about, is all as a result of the generating these brain cells. You understand?
Okay,
It's,
okay,
the
sir.
movement is one aspect of them. What about the hallucinations? What about the delusions? You understand? So it is as a
Yes,
number,
sir.
the bottom line, as you start generating these neural cells, start losing them, then the signs and symptoms start manifesting. Okay? It is relating to how much do you have and how much you lost the number of cells. And therefore, the signs and symptoms exaggerate in that order. So the difference is about the brain cells, how the brain cells are generating, and how much do you have the brain cells intact. That is showing. So if you have so much number of brain cells, then the signs and symptoms becomes vague. So you have, in addition to difficulty or disorder movement, you have, in addition, delusions, hallucinations, memory loss, so many conditions, and that is where you are moving closer to dementia. So it's simply about the number of intact neural cells and the number of generated neural cells. That is all about YouTube. Anyway, let's move on to another condition. This is just one of the conditions we are treating today. So we are moving to another condition from this one. Okay. I went back to your that they said those in Enchi are suffering from network. Sorry for that. It's not only Enchi. Now MTN is so bad. I have to move out of MTN so that you can hear me. You see, I'm using an American broadband. American broadband. It's not even a Ghana network. That is where network becomes stable now. So the network I have connected to you is not a Ghanaian network. It's an American broadband that is giving me stability here in Ghana. So it's not only about Angel. We are all suffering. That is MTN for you. Okay, led to MTN alone, I wouldn't have been able to give you a clear explanation condition of it. Anyway, we are moving to Huntington disease. Isaac Huntington. So what is it? What is Huntington disease? So you see the brain here. It is about the loss of brain cells. You see, look at the diagram there. One of the nerves have been taken out. And if you look at the nerve that is taken out, you could see that there's a brain cell taken out, and the brain cell have electrical impulses, and these electrical impulses move through the myelin sheet. So the myelin sheet that propagates and transmits these impulses. So when this myelin sheet becomes affected, become degenerated, it's like a pothole on the major highway where vehicles fall into these potholes. So you have disordered movement and disordered impulse transmission because of the affected myelin sheet. So that is the diagram there. If you have a smooth and an intact myelin sheet, then the road becomes smooth and the vehicle will move at a speed without any interruptions. That is how I can relate this condition too. If you look at the diagram I have given you, you have two images. The image on the left, you have the normal brain cell. The image on the right, we have a diseased brain cell. So look at the brain with Huntington disease. How do you differentiate it? Look at them very, very well. So here there's neural degeneration. It's a healthy neuron. Yes. How do you compare the two? What do you see? What are the differences? Can anybody come out with any difference? Okay, maybe you take time to observe.
So I want to try.
Yes, let's hear you, my brother.
Okay,
That is
sir.
Destin, right? Yes,
Yes, sir.
Destin.
Yes,
Yeah.
sir. So with
After
the healthy
Destin, then we
brain,
can hear from Raymond. Raymond.
okay, with the healthy brain, we can see that it's more or less close from the apex to the down. You see that from the apex
Yes.
there, it's close, and we can also see that from within the middle of the brain, you can see that there is a tiny small space with left and right. But if you come to the
But you have forgotten your anatomy. You have forgotten your anatomy. That is the hemisphere. Cerebral hemisphere.
Okay.
You are not talking like a professional. Cerebral hemisphere is wider with the Huntington disease, and it is closed for the normal brain cells and the cerebral hemisphere. Okay. Okay. Can we move on? What other difference can you note? Can you notice? Yes. Yes. Okay. Maybe as we move on, we see more difference. Yes. Raymond, you raised your hand. Let's hear you, Raymond.
Okay, good afternoon, doctor. Please, from the images that you showed, the normal brain image, it shows there is a white patch. I think it's the dura mater. That one is smaller as compared to like the one that is being disease, the Huntington disease. That one is more larger than.
Good. You are talking. The dura mater. Dura mater is white here, and it's widely exposed. And then the white matter in the normal brain cell is more or less concealed. That is good, because the cerebral hemisphere is opened. Yeah, you can. It exposes the dura mater.
Thank you.
Thank you. Okay. The same thing applies to these ones. The basal ganglia, the normal brain, and this is what you see. That is the atrophy of the cerebral nerve and basal ganglia. There has been some, you could see some spaces, white spaces, and those are degenerative changes. The nerves have become degenerated, and therefore you don't see any good nerve. So those spaces that you see are the eating away of those brain cells. They have been eaten away, and you see spaces in there. Those spaces in there are the loss of brain cells, and that's the degeneration. So Huntington disease, abbreviated as HD, also known as Huntington chorea. In fact, it's not common. It's a very rare inherited disease that causes the progressive breakdown, degeneration of nerve cells in the brain. So the word here is progressive breakdown or generation of nerve cells in the brain. Huntington disease has a broad impact on the person's functional abilities and usually results in movement, thinking, or cognitive and psychiatric disorders. So do you understand the condition here? As the brain cells loses itself away, there's more problem with movement, thinking, which is cognitive and psychiatric. It just mimics the condition we learned right now, which is so the Huntington mimics the Parkinson. It's all leading to progressive degeneration, breakdown of the brain cells, or number of cells in the brain. But then the difference here is where exactly do we lose the brain cells? Is it close to the basal ganglia? It is close to the substantia nigra? Is it affecting the level of dopamine? Is it balancing the acetylcholine? Then we can differentiate it from Huntington disease. So that is how we need to look at that. That's why I told earlier that the condition is very different at an early stage. It can maintain, it will mimic Alzheimer's, it will mimic Parkinson. You need to do crucial investigation and diagnosis to be able to come out that the person is experiencing Parkinson at early stage. It's very, very difficult to differentiate them. Huntington disease symptoms can develop at any time, but they often first appear when persons are years of the same brain that Parkinson also starts. That is the middle or late age. Start around this age. In the age onset, just like they say for Huntington Parkinson. If the condition develops before age 20, or juvenile Huntington disease. If it develops before age 20, it is called juvenile Huntington disease. When the Huntington develops early, symptoms are somewhat different and they may progress faster. If the condition develops at an early age, then it moves at a faster rate, very, very fast. It is very, very rare. Medications are available to help manage the symptoms of Huntington disease, but then treatment can't prevent the physical, mental, and behavioral decline associated with the condition. So medications are available and only used for treatment, but it cannot prevent or treat. It cannot prevent or treat any or the disease under investigation. You can't treat or you can't prevent it. You can only manage it. You can only manage it. So you can't treat it. So note that medications for Huntington disease can only be used to manage it and not used to treat or prevent or cure. The worldwide prevalence of Huntington disease is 5 to 10 cases per 100,000 persons, but this varies from geographical locations, especially as a result of ethnicity, local migration, and past immigration patterns. Prevalence is similar for men and women. The rate of occurrence is highest in peoples of Western European descent, averaging around 7 per 100,000 people, and is lower in the rest of the world. Example, 1 per million people of Asian and African descent. When it comes to these conditions, Africans are blessed. God has really blessed us. He has taken out these conditions from our part of the world here, Africa and Asia, Spain, because the reason is simple. We don't age to get these conditions. We fast, so we don't age to get these conditions. It is associated with aging. And here in our world here, we die early, but we don't have the necessary infrastructure, and then we don't have the good healthcare systems. Look at my aunt. Just going to remove fibroid. She wasn't sick. At the age of 79, my aunt was not having diabetes, she was not having hypertension, having other conditions. She was just going to remove fibroid. And they'll call her to come and take her body away. That is the kind of world we find ourselves. That is where we find ourselves. Just my myectomy. She's dead and gone. But in Europe and other advanced countries, they would have done this surgery in a very simple manner, even in Ghana here, to get a very good surgeon. I mean, people go in and remove and come out just to have a good surgeon, and you'll be okay. So here we have types. Huntington disease has 2 subtypes. We have the adult onset Huntington disease. So this is the most common form of Huntington disease. The adult onset is common. People with adult onset Huntington disease usually develop symptoms in their mid-40s and 50s. Mid-40s mean that from 45 to 50, you have this condition. And it's the most common type. Adult onset. Juvenile Huntington disease, children and teenagers have this form of Huntington disease, which is very, very rare. It's not common. So children with Huntington disease often have symptoms similar to Parkinson's disease. You see, when children have it, it's similar to what? Parkinson's disease. So the condition mimics each other, so closely related. They may also develop problems with schoolwork. If you have writing check, how can you write well? If you have cognitive impairment, how can you learn in school? If you have a problem with speech, how can you learn actively in school? So all these affect schoolwork, and therefore it really affects the children in that age group. So causes is caused by an inherited defect in a single gene. So Huntington is an inherited disease of a single gene. Huntington disease is an autosomal disorder. So autosomal, I'm going to explain autosomal dominant disorder to you. It means that a person needs only one copy of the defective gene to develop the disease or the disorder. When you say autosomal dominant disorder, if, for example, I have S, big S, and small s, it is in a heterozygous state. But then if I want to pass my 1s to you to call S, I can pass a small s, and you can still pass. Yes. Hello, can you hear me? Hello? Can you hear me?
Yes, sir.
Yes, sir.
Very good. Very good. So what I'm saying is that when we say autosomal dominant inheritance, we mean that always we have a pair of the gene. Autosomal dominant, just a half pair can cause the disease. You don't need the two, or you don't need the pair. Just a half pair can cause the disease, because the two of them, each one, when they are present, can bring about the disease. You don't need the two or the just one pair or half for the disease. Please, is that clear? So with the exception of the genes on the excess chromosomes, a person inherits 2 copies of every gene. That's the explanation. 1 copy from each parent. A parent with a defective gene could pass along the defective copy of the gene or the healthy copy. Each child in the family, therefore, has 50% chance of inheriting the gene that causes genetic disorder. So just you are having a defective gene, so D, and then the good gene, G. So if the D defective gene, D, at every conception, the pregnant woman has 50% chance of producing a healthy or producing a Huntington's baby, because each of the genes have equal chances. Very, very, very simple. I hope it's clear. So the Huntington is expressed in all cells. The highest concentrations are found in the brain cells and the testes. So that's the Huntington disease. They are expressed in all cells, but we have the highest of it concentrated in the brain and then the testes, with the moderate amount in the liver, the heart, and then the lungs. But then majority of its concentrations are found in the brain and then the testes. The function of Huntington's human is unclear. It interacts with proteins which are involved in transcription, cell signaling, and intracellular transporting. In genetically modified to exhibit Huntington disease, several functions of Huntington disease have been found in these animals. Huntington is important for embryonic development, as its absence is related to embryonic death. So we need it for reproduction. And we are saying that this condition is related to an interaction with a protein. And these proteins are involved in the transcription, cell transcription, cell signaling, and intracellular transporting of chemicals or minerals in the cells. So that is what the protein does. The Huntington protein interacts with over 100 other proteins. So we have the Huntington protein interacting with 100 other proteins in the body. And this appears to have multiple biological functions. The behavior of this mutated protein is not completely understood, but it is related to certain cell types. So Huntington protein, we understand, is a mutated protein. It's not a normal protein. Because if it's a normal protein, it will not interact to bring about adverse effect. So they are not a normal protein. So we have the huntingtin protein, which is more like the mutated protein, the protein that has become mutated. And this interact with 100 other proteins in the body and have multiple biological functions. The behavior of this mutated protein is not completely understood. It is taught because the mutated protein will never obey the chemistry of the body, just like cancer cell. To never obey, they do their things without relating to what the body tells them to do. So this toxic or mutated body protein is toxic to the certain cell type of the brain. Some of the cells, the brain cells, when they meet the mutated protein, they get toxic, they get sick. It is found in the brain, destroy some of these brain cells. So the brain cells we know are destroyed by these means when they interact with them. Toxic to the brain cells, and they cause degeneration changes to the brain cells. They destroy them. Early damage is most evident in the stratum. So early damage occurs within the stratum, but as the disease progresses, other areas of the brain are also more conspicuously affected. So initially, it starts with the stratum, as the Parkinson's starts with the stratum, also starts with the stratum. Even the Huntington also start with the basal ganglia. They all start from the same part, but we are getting to know that with Huntington, they spread to affect other areas of the brain. The symptoms are attributed to functions of the stratum and its cortical connections, namely control over movement, mood, and higher cognitive functions. So mood control, movement control, brain thinking, cognitive, they are all affected. DNA methylation also appears to change in Huntington. So Huntington disease really causes movement, cognitive, and psychiatric disorders. These are three: movement, cognitive, and psychiatric disorders. A wide spectrum of signs and symptoms, which sometimes or symptoms appear first varies greatly from person to person. Some symptoms appear more dominant or have a greater function on functional ability, but that can change throughout the course of the disease. So the signs differ from one person to another person. But some symptoms appear more dominant and normally exhibit greater effect on the person than others. When it comes to movement, so there's movement disorders. Huntington disease can include both involuntary movement problems and impairment in voluntary movement. And the movements such as involuntary, jerking, writing movement, that is named for chorea. So as you move, like you are writing. As you move, it's like you are writing. They're like snake-like movement, and that's the name chorea was generated from. Slow abnormal eye movement, so your eye movement, your blink will become slow or abnormal. Either you blink it rapidly or slowly. Muscle problems such as rigidity or muscle contractures, dystonia, that's the name dystonia. Slow or abnormal eye movement, impaired gait, posture, and balance. We saw this in Parkinson. They mimic each other, I'm telling you. Difficulty with speech or swallowing, we saw this in Parkinson's. Impairment in involuntary movement rather than the voluntary. So it is impairment in voluntary movement rather than involuntary movement. There's greater a challenge in producing voluntary movement than the involuntary movement. You may have impact on the person's ability to work, perform daily activities, communicate, and maintain independence. If you have this condition, you can't maintain independence, or else become dependent. Communication becomes a problem, and daily activity becomes a problem. So for cognitive aspects, cognitive disorders, we said there is movement, cognitive, and psychiatric. There are three. So note them. Cognitive, movement, and psychiatric disorders. We have done with the movement. We are now with the cognitive disorders. Cognitive impairment often associated with Huntington disease include difficulty organizing, prioritizing, or focusing on task. Difficulty organizing, prioritizing, or focusing on the task. You go and do one task, you go and do another task, you don't finish, then like that. There are some people, they start the program, they don't finish, they stop, they go initiate another program, they said, me, I don't like, then you see that all on programs. Lack of flexibility or the tendency to get stuck on a thought. As you are communicating with the person gets stuck. The person will be stuck, will not be able to talk. They can't get through. They say thought block. Behavior becomes difficulty, or there's difficulty in behavior, can become at best emotional and aggressive sometimes. Perseveration. So there's what we call perseveration. There's perseveration. The action becomes perseveration. Lack of impulse control that can result in outburst. Acting out, thinking and sexual promiscuity. So you can just take small children and sleep with them because you don't care. The mind is something that's really controlling the mind. You are not with yourself. Some behavior that is outburst, uncharacteristic of that person. You do things. So sometimes when you are driving and people drive carelessly, don't insult them. They may be having problems. Most of the drivers are having problems. Lack of awareness of one's own behavior and abilities. They don't care. They will drive so careless to you. They don't care. They will not even say sorry. Slowness in processing thoughts or finding words. Their thought becomes blocked. They cannot find words. They become slow in terms of thinking. Difficulty in learning new information. So they have problems with school activities. If you want to teach them something new, there's a problem. But they cannot add anything again. What is there is okay. Psychiatric disorders. The most common psychiatric disorder associated with Huntington disease is depression. Continue. Depression, I have also explained to you why there's depression running through. This isn't simply a reaction to receiving a diagnosis of Huntington disease. Instead, depression appears to occur because of injury to the brain and subsequent changes in brain function. So there's that static attack to the brain cells brings about the depression. Signs and symptoms may include feeling of irritability, sadness, or apathy. You feel so irritable. The small thing you get irritated, and you become so sad and apathetic. Social withdrawal, so you withdraw from social interaction, social group. Insomnia, in the night, you stay awake without sleeping. Fatigue, you see the signs and symptoms just Parkinson, just like Parkinson. Fatigue and loss of energy, frequent thought of death, so suicide tendencies. Depression can lead to suicidal tendencies, so dying or committing suicide. So we have other common psychiatric disorders, which include they are obsessive compulsive disorders. Obsessive compulsive disorder, a condition marked by recurrent intrusive thoughts and repetitive behaviors. You close your door and lock it and you leave. At the middle of the road, you come back and check whether the door is locked. You sweep your room. Just a few minutes when the room is not well swept, you sweep again. You step in the car dung and you wash the sole of the slipper about 100 times because still that scent is still there. Repetitive thoughts, repetitive behaviors. Obsessive compulsive disorders. They are well exhibited here. Mania, which can cause elated mood, overactivity, impulsive behavior, and inflated self-esteem. Yes, inflated self-esteem. I am the king of the Ashanti. Yes, everybody should come and talk to me. So you rate yourself so high. Bipolar disorder, bipolar. 1 minute she's crying, the next minute she's smiling and laughing. Bipolar. Manic depressive psychosis, a condition that is alternating with episodes of depression and mania. In the above disorders, weight loss is common in people with Huntington disease, so there's weight loss, really lack of appetite to eat, especially as the disease progresses. Yes, it may affect your olfactory nerves and you can't have smell to eat. Symptoms of juvenile Huntington disease, if the condition affects the young ones, what happens? The smarts or the start and progression of Huntington disease in young people may be slightly different from that of adults. Remember that often present early in the course of this disease include, so the young ones have behavioral changes, difficulty paying attention, rapid significant drop in overall school performance. So check. If there's somebody's school performance dropping significantly, check all these. Behavioral problems, she'll be beating her colleagues so badly, so aggressive. Some children in school, you have no idea what they can do. Behavioral problems, physical changes, contracted and rigid muscles that affect gait, especially in young children. So got the muscle get contracted, that affects their gait. Tremors or slight involuntary movement, frequent falls or clumsiness and seizures. So we saw frequent falls, Parkinson, we are seeing it here. They resemble each other. How do we diagnose? The diagnosis of Huntington disease is based primarily on your answers to questions. You put down a question and expect answers. You see how you can guide them through, and with the answers, you can easily diagnose them. A general physical examination, a review of your family medical history, and neurological and psychiatry examinations. So in your family, do you have any condition in the family? If you have one, then you are more predisposed. Medical history can also be looked at. Neurological and psychiatry examination. So neurological examination, the neurologist will ask you questions and conduct relatively simple tests for you. So you do motor symptoms such as flex, muscle strength, and balance. All this will be done to check, because we said the condition affects facial expressions and some other muscle groups are affected. Sensory symptoms include sense of touch, vision, and hearing. So we also do check on those vision and hearing and touch issues. Psychiatric symptoms such as mood and mental status are checked. Then we have neurological testing, the nerves. So the neurologist may also perform standardized tests to check your memory. So they will check whether the memory is intact or there's something wrong with the memory. Reasoning, ability for you to reason, you'll look at that. Mental agility, for you to be able to go into mental work. Language skills, how smooth is your language skill? Can you speak liberally? Spatial reasoning and psychiatry evaluation. So all this we do check on them. Then we can also look at psychiatry for an examination to look for a number of factors that could contribute to your diagnosis, include emotional state. How is your emotional state? Pattern of behaviors, quality of judgment, coping skills, signs of disordered thinking, evidence of substance abuse. All these are checked. Brain imaging and function. So in brain imaging and function, the doctor may order brain imaging tests for assessing the structure or function of the brain. So imaging, radiological investigation, we can do this. The imaging technologies may include MRI or CT scans that show detailed images of the brain. These images may appeal or reveal changes in the brain in areas affected by Huntington's disease. So once we do take images, definitely when the Huntington's disease attacks part of the brain, we can know. These changes may not show up early in the course of the disease. With the course of the disease, at the beginning, it will be difficult, but later it will show. These tests can also be used to rule out other conditions that may be causing symptoms. We have genetic counseling. Can also be done to know if you are at a higher rate of bringing forth these characters, then we can stop it. Symptoms strongly suggest some Huntington's disease. Your doctor may recommend a genetic test for the defective gene. We said there's a gene which is mutated, and when that gene encounters the brain cells or communicates with the brain cells, they cause toxic effect to the brain cells, and that's how come the brain cells be treated. So we are saying that a genetic test to detect for the defective gene, the mutated gene. This test can confirm the diagnosis. It may also be valuable if there is no known family history or Huntington's disease, or if no other family members' diagnosis was confirmed with a genetic test. So we do this to put down information for the future. But the test won't provide information that might help determine the treatment plan. So all the tests you are doing, it doesn't really provide information for any treatment. It is not. Before having such a test, the genetic counselor will explain the benefits and then drawbacks of learning test results. The genetic counselor can also answer questions about the inheritance pattern of Huntington's disease. So we have what is called predictive genetic test. Apart from the counseling and testing, we have the predictive genetic test. So a predictive genetic test can be given if you have a family history of the disease, but don't have the symptoms. So you see there's a condition here. The predictive test is done on those who have the genetic condition in the family, but they are not showing in the signs and symptoms. So you are going to do the test to see whether you have any chances of experiencing the condition in the future. That is what is called predictive genetic test. This is called predictive testing. The test can't tell you when the disease will begin or what symptoms will appear first. It cannot tell you. Some people may have the test because they find not knowing to be more stressful. Others may want to take the test before having children. So you want to see whether you have any chances of having children in the future. So are the children going to be affected negatively by the disease or not? Risks may include problems with insurability or future employment and the stresses of facing a fatal disease. In principle, federal laws exist that make it illegal to use genetic testing information to discriminate against people with genetic diseases. So that's what people don't want to do. I think it goes into your profile. And in future, if you want to go for any future appointment, they will say that, oh, you did a genetic test, predictive test, and you are likely to have Huntington, so we will not employ you. It can affect your profile if you have it. These tests are only confirmed or performed after consultations with the genetic counselor. So you have to consult with the genetic counselor, come out with the decision. So no treatment can alter the course of the disease. Medication can lessen the signs and symptoms like movement and psychiatric disorders. Multiple intervention can help a person adopt the changes in his or her ability for certain amount of time. So here, the test can help the person adapt to changes in his or her abilities, but it cannot, medication can lessen the signs and symptoms, but can't cure. So medications for movement disorders. Drugs to treat movement disorders include the following. Control movement include, so we have the terbinafine and deutrabenazine, which have been specifically approved by the Food and Drug Authority to suppress the involuntary jerking and writing movement or the chorea associated with the disease condition. So the government has instructed one pharmacist to assist in producing drugs for these conditions. These drugs don't have any effect on the progression of the disease. However, possible side effects include drowsiness, restlessness, the risk of worsening or triggering depression or other psychiatric conditions. So once you do this test, it doesn't bring out any disease or that you are going to cure. But then, see, the drug don't have any effect on the progression of the disease, but the possible side effects are restlessness, drowsiness, and worsening triggering the progression of condition psychiatry. So you do not have any treatment from the medications, but it can slow down the progression of the disease to psychiatric disorders. Antipsychotic drugs such as haloperidol and fluoxetine have a side effect of suppressing movements. So once you use them, haloperidol and fluoxetine, you can suppress the movement by their side effect. Therefore, they may be beneficial in treating chorea. However, these drugs may worsen involuntary contractions, like dystonia, restlessness, and drowsiness. Other drugs such as risperidone, olanzapine, and quetiapine may also have few side effects, but still should be used with caution, as they may also worsen the symptoms. So you have to be careful when you are using these drugs. Other medications that may help suppress chorea include amantadine, Labrate, so that is the levetiracetam, yes, and clonazepam, but they may have their effects, and because of the side effects, limit their use or their usage. So there's medication for psychiatric symptoms or disorders. Medications to treat psychiatric disorders will vary depending on the disorders and symptoms. Possible treatment include the following: antidepressants, because they said there will be depression, so antidepressants, and this includes such as citalopram, fluoxetine, so we have the Prozac or Sarafin, sertraline. These drugs may also be used, or they may also have some effect on treating obsessive compulsive disorders, and side effects may include nausea, diarrhea, drowsiness, and slow blood pressure. So if you take these medications, it's not 100% scot-free. You're going to have some side effects. Antipsychotic drugs such as quetiapine, risperidone, and olanzapine may suppress violent outbursts, agitation, and other symptoms of mood disorders or psychosis. However, these drugs may cause different movement disorders themselves. Mood stabilizer drugs that can help prevent the highs and lows of bipolar disorders include anticonvulsants such as divaprox, carbamazepine, and have the so these medications are very, very good and help manage the condition. Psychotherapist, a psychiatrist, a psychologist, or clinical social worker can provide talk therapy to help with behavioral problems, developing coping strategies, justifications during progression of the disease, and facilitate effective communication among family members. So that is the work of the psychotherapist. So he comes in to integrate the person back with our family. Speech therapy. Disease can significantly impair control of muscles, the mouth, and throats that are essential for speech. Yes, we said there'll be speech problems. So the medication is going to control the movement at the mouth for speech. Mouth and throat that are essential for speech, eating, and swallowing. These structures, the medication works around that. A speech therapist can help improve ability to speak clearly or teach you to use communication devices, such as board covered with pictures of everyday tasks and activities. Speech therapists can also address autism with muscle used in treating and swallowing. So we have the physical therapist. We said there will be problem with movement, and the physical therapist comes in here to check movement, or you help you with movement issues, the speech issues. The physical therapist comes here to help. So physical therapists can teach you appropriate and safe exercises that enhances strength because of the muscle fitness and then the rest. So the physical therapist comes to give you specific exercises to strengthen the muscles and relieve you of stiffness at the joint and the weakness in the muscles. Flexibility, balance, and coordination all will be taught by the physical therapist. These exercises can help maintain mobility as long as possible and may reduce the risk of falls. So it is very important to visit the physical therapist to take away all those frequent falls because the exercise can help you prevent them. Instructions can on appropriate posture and the use of supports to improve posture will help lessen the severity of some movement problems. So instructions on appropriate posture, they will tell you that if you stand like this, don't stand like this. So there are instructions on posture, and then the use of support to improve posture can also lessen some of the severity. When the use of a wheelchair or walker is required, the physical therapist can provide instructions on appropriate use of the device and the posture. So if you want to use any walking aid, it is the duty of the physical therapist to help you get one. Also, exercise regimen can be adapted to suit the new level of mobility. Occupational therapy. An occupational therapist can assist in persons with Huntington disease, family members, and caregivers on the use of assistive devices that improve functional abilities. These strategies may include handrails at home, so the stairs may have handrails, or the bathroom may have handrails so that they can hold on these handrails and walk without falling. Assistive devices for activities such as bathing or dressing rooms, handrails could be there. Eating and drinking utensils adapted for people with limited fine motor skills. So nurse management, prevent injury and possible skin breakdown. You need to do that. Pad the sides and hairs of the bed because they can be hitting their head against the bed. So pad all the sides of the bed. Keep the skin meticulously clean. Encourage ambulation with assistance to maintain muscle tone. Secure the patients in bed or chair with padded protective devices, making sure they are loosened frequently. Keep patients as close upright as possible while feeding to prevent aspiration. Stabilize patients' head gently with one hand while feeding because they may be shaking their head uncontrollably. The nurse needs to educate and support the patient and family as they adjust to the lifestyle changes that are required. So the nurse, you need to educate the family for support because it's going to adapt to a new lifestyle together. The actions and potential side effects of medication regimen need to be taught, monitored, and adjusted to the desired patient response. Regular moderate exercise can reduce stiffness and tremors. As the disease progresses, the patient and family will require more assistance with activities of daily living, emotional support, and potential financial concerns, such as going to the bank, you need assistance, using the teller machines, you need assistance, or even when monies are paid to him or her, you need somebody to guide because they've lost their cognitive aspect and you need somebody to assist in their finances. So we can have weight loss as a complication, pneumonia due to malnutrition can be there, congestive heart failure can also be there because of the medications. Incapacitated bed sores can also be because of loss of muscle movement. We welcome contributions, discussions, questions, for contributions, for clarity, for explanation. Yes. Yes, you see, Mavis, I didn't have problem with American broadband. You see, you use MTN and you are having issues. Mavis, John, when I use American broadband, have you seen any disruptions in the voice? Get American broadband. Mavis, go and get one. Hmm? Mavis, Sean,
Yes, sir. Sir, I've heard you.
go and get American broadband. Yes, go. So you don't have issues with network, eh? Yes. Yes. So can we hear from your end? The two conditions mimic each other. They are causals, they are risk factors, so you need to be careful. That is why it is difficult to distinguish them at the initial stages. Very, very difficult. Any contribution so far? Any questions? Any questions, please? Contributions from the class? Yes. I don't want to start with Alzheimer's disease because we may not finish. We want to start on a fresh. What do you think? Can we continue? Should we continue?
Sir, please, I think we should start next week.
Yes, so we can really understand. We can really go and think about things. I don't want to overburden you with more. You get confused. On the first day, we start with Alzheimer's, and then we move on to other nervous system conditions. But you can think about these two very well, and we appreciate how it is managed, detected, and how it can be controlled. You cannot cure it, the two. You only have to manage it. You have to put preventive measures, have to eat well, have to make sure we avoid toxins from the galamsey site, make sure that we avoid infections that may destroy the nerves. We make sure that we check in our families. If we have any family member, we start putting measures to prevent the occurrence of one in our families or in our house. So let's be watchful. We are lucky Africans, we are not, but now because of the influx of people, you see, we are not protected. Now you can have a Chinese person coming here and then before that they have gotten married to a Ghanaian, and that is a mixed descent, you understand? So you got to be careful, Yes. All right, so if there are no questions and answers or questions, we bring the lecture to an end. You can go and rest, then you can continue from tomorrow, God's willing. May the good Lord be with us. We'll meet next week. Bye-bye.
God bless you, too.
Thank you, sir. God bless you.
Thank you. Bye-bye.
Happy Father's Day.
Bye-bye. Thank you. Thank you so much.
Happy Father's Day.
Thank
In
you.
advance, thank
That
you.
is Sunday, right? Yes. Thank you so much.
Please, the slice.
Yes, I have already sent you the slides. So these two. Okay, I will send these two to the rep. She will send it to you. Okay.
Thank you.
Fine. You get them.
Thank you, sir.
Thank you.
Thank you.
Send it. Don't worry.
Hey, Masoya, no, yes, I'm going to slice. So now, hey.
They are suffering from Alzheimer's disease.
Like, baby Sayo.
Yeah? I don't know.
Syrian Premier. 55. The number of women. The number of women 55. But your TV antenna out of your antenna out there. No dish, no, I know much to put now with that antenna.
Cut 3 minutes.